Good morning, ladies and gentlemen. Before anything else, I would like to congratulate everybody present in this classroom for being present today during these difficult times. And I really appreciate your presence today. But before we start with the lecture, which is about portal hypertension and peritoneal diseases, I would like to start with a prayer that we can offer for everybody, especially those who are affected by the coronavirus, the ill, and those who have died recently, and for our colleagues, the frontliners, who are doing everything to treat patients with the virus, and that they're risking their lives just to do this and to help us and protect us from the virus. So let us pray. Our Father, who art in heaven, holy be your name. Your kingdom come. Your will be done on earth as it is in heaven. Give us this day our daily bread. Forgive us our sins, as we forgive those who sin against us. Do not bring us to the test, but deliver us from evil. For the kingdom, the power, and the glory are yours, now and forever. Amen. Mary, our seat of wisdom, pray for us. Again, good morning. For this morning, this is basically what we're going to discuss. We're going to talk about peritoneal diseases. We will discuss peritonitis, of course, primary and secondary peritonitis, but we will not be discussing acute suppurative peritonitis because this is a topic that will be discussed in other fora, and this is most specifically discussed in surgery. We will talk about ascites and, of course, a very important pathophysiologic mechanism of ascites, which is portal hypertension. And lastly, we will be talking about tumors of the peritoneal cavity. We will discuss in both primary and metastatic tumors involving this particular part of the body. So let me start off with the problem of portal hypertension. And before anything else, this is just a cartoon of the anatomy of the portal circulation. These are the important blood vessels which is contributing to the portal circulation. And you can see here the splenic vein, which joins the inferior mesenteric vein. And after joining the inferior mesenteric vein, they will join the superior mesenteric vein in order to form the portal vein. And of course, you can see here in the parenchyma of the liver, the intrahepatic veins, and then eventually the inferior vena cava. What follows after this, of course, is something that you have learned in anatomy and physiology. Shows us the types classification of portal hypertension according to the size of increased resistance to portal flow. We have, of course, the prehepatic causes of portal hypertension, and we have here, of course, the splenic vein thrombosis and the portal vein thrombosis. Portal vein thrombosis is very common in young individuals, in pediatric patients who have portal hypertension, and this is usually due to the manipulation of the umbilical vein after birth. We also have the posthepatic causes of portal hypertension. Very common among disease posthepatic causes would be your Budd-Chiari syndrome, and this is basically an obstruction to the flow of your inferior vena cava. And as you can see here, there are a lot of diseases of the right side of the heart which are reasons for posthepatic portal hypertension. But of course, the most common cause of portal hypertension would be the intrahepatic causes, and among these, the number one reason for intrahepatic portal hypertension would be, of course, your liver cirrhosis, and liver cirrhosis can be due to a lot of diseases. There is one other disease which is very common in our country, especially in the Visayas and in northern Mindanao, which is schistosomiasis. This is, of course, as you know, a parasitic disease that leads to cirrhosis, and this is, of course, the pre-sinusoidal type of intrahepatic portal hypertension. So how do we define portal hypertension? Portal hypertension is basically defined as an pathologic increase in the portal pressure, in which the pressure gradient between the portal vein and the inferior vena cava, or what we call as the portal pressure gradient, is increased above the normal limit of 5 millimeters mercury. The portal pressure gradient is between 6 to 10 millimeters mercury. This is basically what we call as subclinical portal hypertension because portal hypertension can be present, and yet there will be no clinical manifestations of this condition. When does your portal hypertension become clinically significant? It becomes clinically significant when it is more than 10 millimeters mercury, and at this point, varices already to start to form, especially in the gastroesophageal region, and when it is greater than 12 millimeters mercury, variceal bleeding and ascites starts to form. When we talk about portal hypertension, we can basically presume and assume that 90% will be most likely be due to liver cirrhosis, and only about 10%, less than 10% will be due to non-cirrhotic causes. However, whatever the basic pathophysiologic mechanism, the fundamental hemodynamic abnormality in portal hypertension is resistance to portal blood flow. This is again a cartoon of the common portosystemic anastomotic sites that usually occur in patients with portal hypertension, and this is what we call as the collaterals that develop between the portal circulation and the systemic circulation because of the portal hypertension. Basically, the portal collaterals or the systemic portosystemic anastomosis usually occur in order to decompress the hepatic sinusoids which are under pressure, which is under, of course, portal hypertension. The most important collateral that usually develops is, of course, a collateral between your portal vein and your gastroesophageal veins through your coronary veins, and that is why patients with portal hypertension will develop gastroesophageal varices. The other portal collateral that can usually be seen, of course, would be the collaterals that form because of the connection between your vestigial umbilical vein and then your left intrahepatic vein, and this usually leads to the development of your blood vessels, which are very prominent around the umbilicus, which is what we call as your caput medusae. The other collaterals, of course, would be in the retroperitoneal area, and this usually will lead to the development of your pancreatico-duodenal collaterals, sometimes responsible for the formation of varices in the first and second portion of the duodenum. This is quite rare, but sometimes we see patients with massive bleeding coming from collaterals in this area. The last but not the least, of course, would be the formation of collaterals between the inferior mesenteric vein and the pudendal veins, leading to the development of rectal varices in patients, again, with portal hypertension. This can also present as hematochezia in some patients with portal hypertension. So, how do we diagnose the presence of portal hypertension? There are different ways of establishing the presence of portal hypertension. There are very invasive procedures, which are basically your indirect and your direct methods. We don't do this in clinical practice. These are things or tests that are usually done in research laboratories. What we have actually in our armamentarium in order to establish the presence of portal hypertension would be just the indirect signs that we see on physical examination and when we do endoscopy and other ancillary procedures. There are several important indirect signs on physical examination that will point to the presence of portal hypertension, but one very important physical examination finding that, of course, points to the presence of portal hypertension would be the presence of splenomegaly. Aside from splenomegaly, ascites is also important. Is also an important physical examination that points to the presence of portal hypertension. When we do endoscopy, if a patient has varices, obviously this is correlated to the presence of portal hypertension. And when we do other ancillary procedures like ultrasound, which is a very simple test and very sometimes accurate, it is easily accessible. This can also point to the presence of portal hypertension by the findings that we see on the portal vein and the spleen. And I have a slide of this that will show you the ultrasonographic findings of portal hypertension. There are several complications of cirrhosis, especially in patients with pulmonary hypertension. Of course, one of these is hepatic encephalopathy, which we will discuss. And in subsequent slides, and of course we will also be discussing variceal hemorrhage. We will not be discussing hepatopulmonary syndrome and the portopulmonary syndrome because these are quite rare complications of portal hypertension. But the most common complication of portal hypertension, of course, is ascites. And I can see in this slide that 25% of patients with cirrhosis will eventually develop ascites in 5 years' time, and about 60% of patients with cirrhosis will develop ascites in 10 years' time. These are very important data to remember if you're treating patients with liver cirrhosis, because you can always tell the patient that if they are initially compensated, meaning that they don't have any manifestations of the liver cirrhosis, that in 5 to 10 years' time there is a 25 to about 60% chance of developing ascites due to the portal hypertension that comes with liver cirrhosis. Ascites is a very important landmark in the natural history of liver cirrhosis and portal hypertension, because with ascites you also predispose the patients to other complications associated with this problem. And these are, of course, refractory ascites, spontaneous bacterial peritonitis, your hepatorenal syndrome, and of course hyponatremia. These are the complications that we will try to discuss one by one later in subsequent slides. It's only important at this point in time to remember that these complications, these 4 complications, usually will not develop unless there is ascites in a patient with liver cirrhosis and portal hypertension. If we look at the natural history of liver cirrhosis, whatever the reason for the liver cirrhosis, you can see that in those already cirrhotic, about 10 to 15% of them in 5 years' time will develop hepatocellular carcinoma, and this is one of the reasons why we do routine surveillance of patients with liver cirrhosis. And how do we do surveillance? We do ultrasound at least every 3 to 6 months to make sure that no new nodules are developing in a patient with liver cirrhosis. And in about 23%, as I mentioned previously in my last slide, 23 to 25% will develop liver failure in about 5 years' time, and this is what basically we refer to as decompensation. We say that the patient has compensated liver cirrhosis if the liver is able to still meet the metabolic demands of the body, and that's why the patient is basically asymptomatic. There will be evidences of liver cirrhosis by ultrasound, by CT scan, or biochemical tests, but basically the patient will be asymptomatic. However, over time, the patient will decompensate. The patient will go into liver failure. And what are the important manifestations of decompensation? These are the important manifestations of decompensation. The patient will develop ascites, the patient will be jaundiced, the patient will develop portosystemic encephalopathy, and the patient might bleed from varices. Lately, it has also been considered that if the patient develops HCC, that this is also a sign of decompensation of liver cirrhosis. So it's very important that if you hear the diagnosis of a liver cirrhosis that is decompensated, you probably would imagine a patient who already has either ascites, jaundice, encephalopathy, or who has bled from already varices in the esophagus or elsewhere. And as you can see here, unless something definitive is done, like a liver transplantation, a patient will eventually die because of these complications. Liver transplantation is an accepted form of treatment of patients with liver cirrhosis. However, this is something that is quite expensive and rarely done in our country because of so many cultural reasons. So let us talk now about ascites. Ascites comes from the Greek word askos, which means bag or sack. And you will understand from the pictures I will show later on why it's called a bag or sack. But from the medical standpoint, ascites is basically the pathologic accumulation of fluid. Bakit napunta dyan? And now we know that ascites will never occur unless there is portal hypertension, and the portal pressure gradient should be at least greater than 12 millimeters mercury in order for ascites to form. If the portal pressure is greater than 12 millimeters mercury, there would be several events that will eventually occur. There will be increased nitric oxide. There would be vasodilation because nitric oxide is a very strong vasodilator. And because of the vasodilation, there would be a decrease in the effective arterial blood volume. There would be an increase in your plasma levels of vasoconstrictors. There will be a stimulation of your renin, angiotensin, aldosterone system or axis. And because of this, there will be a net renal sodium retention, and eventually, through several other mechanisms, there will be ascites formation. Basically, the most important message of this slide, of course, is that there should be portal hypertension for ascites to develop in patients with liver cirrhosis. So, when we see patients with ascites and we say that the patient has non-cirrhotic ascites, we're probably 25% right. And what are the non-cirrhotic causes of ascites? Number one, of course, would be malignancy, and this will be followed down the line by cardiac failure, pancreatitis, and other causes. But we will be about 75 to about 85% correct if we say that the ascites is secondary to liver cirrhosis, whatever the reason be. It can be ethanol, chronic hepatitis B, NAFLD, or NASH, or autoimmune hepatitis. These are the most important reasons or etiologies of liver cirrhosis. I have to emphasize that you will not develop liver cirrhosis because of fatty liver. There has to be an element of necrosis and inflammation, scar formation before cirrhosis will develop. That is why there has to be non-alcoholic steatohepatitis before cirrhosis will develop. So as I said, you'll be 75 to 85% correct if you say that the ascites is secondary to liver cirrhosis. And as we have stated earlier in the previous slides, about 60%, 25 to 60% will eventually of patients with cirrhosis will develop ascites in 5 to 10 years. The presence of ascites is a harbinger of poor prognosis in patients with liver cirrhosis, and as you can see in this slide, that the probability of mortality is almost about 40% in the first year after ascites appears, and again 50% chance of mortality in 2 years' time when ascites appears. So with this alone, you can, of course, intelligently tell your patients or the relatives of your patients that because the patient already has ascites, that there's a 40% chance of dying in 1 year and a 50% chance of dying in 2 years' time. The most important predictors of mortality in patients with liver cirrhosis who already have ascites are hyponatremia, hypotension, the elevated serum creatinine, and a low urine sodium. Among these four, it is usually hyponatremia and elevated creatinine, which is greatly associated with mortality in patients with cirrhosis and presenting already with ascites. So, we move on into the complications that can potentially occur in a patient with ascites. These are complications that will never occur in patients without ascites. Number one, of course, is your hepatorenal syndrome. This is easy to remember because the most ideal, or maybe the simplest form of the definition of hepatorenal syndrome is that there is an elevated serum creatinine level of about 1.5 milligrams per deciliter in a patient who has decompensated cirrhosis with ascites in the absence of shock, absence of intake of nephrotoxic agents, and the absence of intrinsic renal disease. This is also referred to as hepatorenal syndrome if the serum creatinine of a patient with liver cirrhosis does not improve after you withdraw the diuretics and the patient receives adequate volume expansion with IV albumin. So whenever you see this situation in the clinics, then you can probably easily say that this is hepatorenal syndrome, but just always remember that this must be used in a patient in the setting of cirrhosis with ascites. This one is important because when hepatorenal syndrome occurs, the mortality is very high, and sometimes it's about 70 to 80% in 6 weeks to about 3 months' time. So what is the mechanism for the development of hyponatremia in patients with liver cirrhosis? Again, you can see here that because of portal hypertension, the patient will develop systemic and splanchnic vasodilation, and because of this, because of the diminished effective arterial blood volume, there will be an activation of your renin-angiotensin-aldosterone axis. There will be also an activation of your sympathetic nervous system. This would lead, of course, to sodium retention and to systemic vasoconstriction. Moreover, there's also an activation of your antidiuretic hormone, and because of this, there will be, of course, a retention of solute-free water, leading to what we refer to as dilutional or hypervolemic hyponatremia in patients with cirrhosis and ascites. Again, it's very important to remember that in patients with liver cirrhosis and ascites, it is hypertension that is one of the more important mechanisms for the development of hyponatremia, and that the hyponatremia in patients with cirrhosis and portal hypertension is not necessarily due to increased loss of sodium, but basically because of dilutional hypervolemic hyponatremia. When do we consider a patient as having hyponatremia in this condition? A serum sodium of less than 130 milliequivalents per liter is considered to be hyponatremic, but what is clinically important is, of course, a level that is lesser than 120 milliequivalents per liter. This is clinically significant, and the patient must be treated, or else the patient might develop serious complications because of this electrolyte imbalance. What is the clinical significance of hyponatremia in patients with ascites? We have learned again in the previous slides that this is a significant predictor of mortality. This is one of the two important predictors of mortality aside from an elevated serum creatinine in the setting of patients with hepatorenal syndrome. Among other things, it's also a predictor of adverse prognosis. And you can see here all the adverse events that can potentially happen to a patient with liver cirrhosis and ascites, and of course with hyponatremia. And that is why if you correct or you are able to diagnose the presence of hyponatremia in these patients and able to correct it, then you can potentially prevent these adverse events happening to these individuals. So what is refractory ascites? Again, there's a simple way of remembering the definition of refractory ascites, but before anything else, when we see patients with liver cirrhosis and ascites, initially the mainstay of the treatment of these patients with ascites is, of course, to limit the dietary sodium intake and cut it down to about 88 milliequivalents, or about 2,000 milligrams per day of sodium. And of course, together with this, we administer two diuretics together simultaneously, a single dose every morning. This is about 40 milligrams of furosemide combined with 100 milligrams of spironolactone. That is usually the ratio, 40:100 or 100:40, whatever you prefer to use. But you see, one of the parameters to say that the patient's ascites is responding to the treatment is, of course, weight loss. If the patient continues to gain weight over time, this is an indication that the ascites is not being mobilized, and that is why we gradually increase the dose of furosemide and spironolactone. We maintain, of course, the dietary sodium restriction, but gradually increase over time the dose of furosemide and spironolactone. However, if we reach this dose of about 160 milligrams of furosemide and 400 milligrams of spironolactone, and the patient is still not responding, meaning the patient is not losing weight and there is no mobilization of the ascites and the peripheral edema, then we already consider the patient as having refractory ascites. So one of the simplest definitions, of course, is the failure to respond to the maximum doses of furosemide and spironolactone, which is 160 milligrams to 400 milligrams of spironolactone. The other definitions of refractory ascites, of course, is the rapid reaccumulation of fluid after we do therapeutic paracentesis, despite, again, the adherence to a sodium-restricted diet. I will explain to you later on what therapeutic paracentesis is, but basically this is just an aspiration of the ascitic fluid. And if sometimes we aspirate as much as about 5 to 6 liters of acidic fluid in patients with ascites, but if this rapidly reaccumulates in about 4 to 7 days' time, then this can be considered as refractory ascites. And lastly, if the patient develops complications related to the intake of diuretics, this also can be considered as having refractory ascites. So the other complication that comes with the presence of ascites is spontaneous bacterial peritonitis, which is also referred to as your primary bacterial peritonitis. This is basically defined as the acidic fluid infection without an evident intra-abdominal surgically treatable source of infection, meaning to say that there is no intra-abdominal disease that needs surgical treatment, like a patient who has appendicitis, bowel obstruction, cholecystitis, or maybe even a perforated viscus. This develops in about 10 to 30% of patients with ascites, and it has a very high mortality, about 20%. We have to remember that this complication of spontaneous bacterial peritonitis, or the primary bacterial peritonitis, only is considered in patients in whom you have ruled out other secondary causes of peritonitis, and of course it only occurs in patients with decompensated liver cirrhosis and ascites. If we take a culture of the acidic fluid in patients with SBP, you usually will get a pure growth, meaning you probably will only get one kind of bacteria most of the time. These are gram-negative bacteria, your E. coli and your Klebsiella. And if you examine the acidic fluid under the microscope, the polymorphonuclears, or your white cells, would be greater than 250 per cubic mil. And this is one of the basic definitions of an infected acidic fluid. If at any time you see an acidic fluid that has greater than 250 white cells per cubic mil, then this means that this is an infected acidic fluid and the patient deserves to be treated empirically. These three are the criteria for making the diagnosis of spontaneous bacterial peritonitis. There is no surgically treatable source of infection. There is a positive culture, and the acidic fluid has greater than 250 white cells per cubic mil. Again, as I mentioned earlier, this will occur usually in patients with severe liver disease, usually in patients whose acidic fluid is less than 1 gram per deciliter and whose total bilirubin is greater than 2.5 milligrams per deciliter. How do we treat patients with spontaneous bacterial peritonitis? Usually the drug of choice is a third-generation cephalosporin, and this is of course your cefotaxime. There are other antibiotics that can be used in patients with this problem, but usually it is based on culture that we get in 3 to 5 days time after doing a diagnostic paracentesis. So what is the pathogenesis of spontaneous bacterial peritonitis? Again, portal hypertension, as you can see here in the uppermost part of the slide, is a very important component in the pathogenesis of spontaneous bacterial peritonitis. The patient will have to have this problem in order for the ascites to develop, and you have to have ascites in order for SBP to occur. And again, because of this hypertension, there will be intestinal bacterial overgrowth, followed by eventually by translocation, and because of the translocation, there will be bacteremia. After the bacteremia, there will be acidic fluid seeding, and because of the seeding of the acidic fluid, you will have a patient with spontaneous bacterial peritonitis. Again, this is a very serious complication of patients with liver cirrhosis and ascites because the mortality is significantly high. So when do we start antibiotics in patients with spontaneous bacterial peritonitis? You have to remember that at the outset, you do not have the aid of a culture and sensitivity when you're examining patients with liver cirrhosis and ascites, and that is why sometimes empiric antibiotic treatment is started in these patients, especially in this setting. When the patient is febrile, when there's abdominal pain or tenderness indicative of the possibility of peritonitis, where there's a change in the mental status, meaning a patient might have already portosystemic encephalopathy, because any form of infection can trigger portosystemic encephalopathy. And when the ascitic fluid has this white count, again, as I mentioned a while ago, greater than 250 WBCs per cubic mil. As I mentioned, the antibiotic of choice initially would be a third-generation cephalosporin or cefotaxime, but after treating the patients with cefotaxime and the patient improves and recovers from this infection, it is very important that we should prevent another recurrence of SBP. Recovery from an initial episode of SBP does not protect them from other episodes of SBP in the future. That is why they must continue to take prophylactic antibiotics, and sometimes this is taken indefinitely depending on the clinical situation where the SBP occurred. The drugs of choice usually for prophylaxis are all of these antibiotics now in front of you. I highlighted and capitalized norfloxacin because this is the #1 drug that is used for the prophylaxis of spontaneous bacterial peritonitis. So, how do we diagnose ascites? I cannot overemphasize at this point in time, ladies and gentlemen, that in order to make a diagnosis of ascites, that you must do a comprehensive history and a very thorough physical examination, obsessive compulsive type of physical examination, because these two maneuvers alone, the history and the physical examination, in 95% of cases will tell you that the patient has ascites, and about 75 to 85% you can probably determine already the reason for the ascites. These, of course, are good signs of good clinicians, and I hope that in the future you will be able to make a diagnosis of ascites and the reason for the ascites just by simply doing a good history and a good physical examination. However, sometimes we have to proceed to doing diagnostic tests. We call ancillary procedures. The simplest test, of course, will be an ultrasound, and this will definitely show the presence of fluid in the peritoneal cavity and sometimes give us clues as to the reason for the ascites, and of course as to the possible presence of portal hypertension. More expensive tests like CT and MRI sometimes might be necessary, but usually in other settings. Sometimes, if after doing the ancillary procedures, especially what I have just mentioned together with the blood chemistries, we might have to do paracentesis in order to really determine the reason for the ascites, and I discuss this with you later on. And in the past, when I was still in training, we used to do a lot of laparoscopies. This is what we call a peritoneoscopy, and I have some pictures of this that I will show you later on. We insert a scope through the umbilicus into the peritoneal cavity, and we can see the entire peritoneal cavity and see the changes on the surface of the liver and determine the reason for the ascites. This now is rarely done because after the blood chemistries and the other advanced diagnostic tests, laparoscopy is rarely necessary at the present time. These are just pictures of patients with liver cirrhosis, not necessarily with ascites. This is just showing you a patient with jaundice. This lady on the left side is a Caucasian woman, but what is very clear here is that the sclera is yellowish there, but in this other guy on the right side, on your right, it's very obvious that the patient is. This one will show you the classic changes in the color of the urine. We have the highly colored urine, or what you usually refer to as tea-colored urine. We try not to use the phrase tea-colored urine nowadays because there are so many colors of tea now in the market. You can have green, pink, or even orange tea. Of course, this is pulmonary erythema. These are due to the hormonal changes that usually occur in patients with liver cirrhosis. If you see this, always think of the possibility of liver cirrhosis, although it can be found normally in some Caucasian people. This one is not quite so clear, but you can see here some areas of hematomas and red spots here. You can even see a band-aid here on top, maybe a site of puncture, but this is just simply showing you the easy bruisability in patients with liver cirrhosis because of the coagulopathy that is present in a lot of patients with liver cirrhosis. This is, of course, an extreme case of an individual with jaundice, and what I'm trying to show you here is not the jaundice, but because of the obstruction, the biliary obstruction that led to biliary cirrhosis, you can see here deposits of fat in the subcutaneous area here around the eyes and here just around the neck of the patient, and these are the deposits of fat in the subcutaneous tissue. This is secondary to biliary obstruction. You know that bile is very important in fat metabolism, and because of biliary obstruction, fat metabolism of course becomes abnormal and there would be deposition of fat in the subcutaneous tissue. This will simply show you, I know that you might be wondering whether the patient has liver cirrhosis or not, but this is shown in order to emphasize the presence of your parotid gland enlargement in patients with advanced liver cirrhosis. And this would be the classical prominent veins around the umbilicus or your caput medusae in patients with portal hypertension. This is a closer view of that individual, and you can see here the umbilicus and the very prominent veins around the umbilicus. This is caput medusae in patients with liver cirrhosis and portal hypertension. And of course, another finding here would be the presence of gynecomastia in this male individual, again secondary. And of course, the classical finding in a patient with ascites, you can see here, you have a distended abdomen, symmetrically distended abdomen, meaning to say that this is probably not secondary to a mass, because if this is secondary to a mass, the abdomen would be asymmetrical. For example, if this is secondary to a mass in the liver, this area would be more prominent than the rest of the abdomen. But you can see here very clearly that there is a symmetrical distension of the abdomen, and one other clue, of course, is you have the everted umbilicus. This is, of course, the umbilicus that is being pushed by fluid, and there is some scrotal edema over here. Again, this is why ascites is called a bag or a sac. You can see this male patient with a huge symmetrically distended abdomen that looks like a bag or a sack that he is carrying. This is another case of ascites. This is obviously in an elderly female patient, and you can see that this patient is emaciated and had lost a lot of weight. And this ascites, of course, in this patient is not secondary to liver cirrhosis, but it turned out to be ascites secondary to an ovarian malignancy that led to carcinomatosis. And this is one caveat here, is that when you see female patients who have ascites, always make sure that the ascites is not secondary to a gynecologic malignancy. This is a picture of an ascitic fluid that is spurting out from a ruptured umbilical hernia, and you will learn later on that this is one of the indications for doing an emergency therapeutic paracentesis in patients with this problem, because this one becomes a portal for infection and the patient might develop spontaneous bacterial peritonitis. There are several underlying pathophysiologic mechanisms of ascites, but these are the three more important. The most important, of course, is portal hypertension, which can be found in patients with cirrhosis, and of course these other diseases here. You can see here down the line. The reason, of course, is hypoalbuminemia that can be found in patients with nephrotic syndrome, with patients in severe malnutrition, and of course in patients of peritoneal disease. If peritoneal disease is the reason for ascites, always be wary of the fact that the ascites might be secondary to malignant ascites, because this is the most common reason for ascites in patients with peritoneal disease. There are other reasons, of course, here, like eosinophilic gastroenteritis, infectious peritonitis like TB peritonitis, but always be wary of the fact that it might be secondary to carcinomatosis. There are other etiologies, but these are quite rare. Probably some of these diseases you will never encounter in your clinical practice. When we see patients with ascites, we usually grade them, and patients with grade 1 ascites usually just have mild ascites, and this is the ascites that is only detectable by ultrasound. When we see ascites by ultrasound, most of the time it is only about 150 ml. And as I said, this is only detectable by ultrasound, so that most of the physical examination findings will be negative. And that is why when you are in the ward later on, when you become clerks, and hopefully you will be given the opportunity to start clerkship as soon as possible. If you see patients in the ward and your resident or your intern tells you that the patient has mild ascites, probably you should not believe him or her unless he or she shows you an ultrasound with this picture. As I said, this is not detectable by physical examination. This, of course, this black thing is the ascitic fluid. Water and air is usually black by ultrasound. When the patient has grade 2 or moderate ascites, then most of the physical examination findings of ascites will already be present, like your shifting dullness. This will already be present, and the abdomen, of course, will be symmetrically distended. And in patients with grade 3 or large ascites or severe ascites, there's already marked abdominal distension, and aside from the marked abdominal distension, the patient will also have peripheral weight loss, and you can see that the extremities are already thinned out, and aside from the peripheral weight loss, the patient will already be symptomatic because of the severe ascites. This is one of the more important physical examination findings that you will see in patients with ascites, and this is the shifting dullness. I'm sure this was already properly explained to you when you were in Medicine 1, but I would just like to reiterate at this point in time that if your shifting dullness is positive, there's about 1.5 liters of fluid already in the peritoneal cavity. And how is this done? You let the patient lie down prone, and when in this position, the fluid will gravitate towards the lateral aspects of the abdomen, so that when you percuss at this point here near the umbilicus, this area will be tympanitic. But if you percuss at the sides of the patient, it will be dull because of the fluid. And when you turn the patient either to the right or to the left lateral decubitus, after 5 or 10 minutes, the fluid will gravitate towards the lower part of the abdomen, and you will hear by percussion that this area will be tympanitic, and this, of course, will be dull because of the fluid. And this is classical and typical shifting dullness. If this is positive, you don't have to do the fluid wave, which of course was again taught to you in Medicine 1. The fluid wave is one of the most cumbersome tests to do and to look for ascites, because you need a third person to put his or her hand across the abdomen before you can do the fluid wave, and that's why there's a lot of false negative and false positive that comes with this test. Just remember that when you are suspicious of ascites, the only important physical examination finding that you probably must do would be the test for. As I mentioned in my previous slides, when we see patients with ascites, sometimes we have to do paracentesis in order to probably determine the reason for the ascites. There are two reasons for doing paracentesis, which is the aspiration of the peritoneal or the ascitic fluid. One, of course, would be diagnostic reasons, and the other one would be therapeutic reasons. When is it diagnostic? Diagnostic paracentesis is just a removal of the aliquot of the peritoneal fluid, approximately about 50 to 100 ml, for examination. Like when there is an ER visit or hospital admission of a patient with this problem, when there are signs of infection, when there are signs of deterioration like renal failure or new onset encephalopathy, and when there are signs of worsening of liver function, then obviously you have to do diagnostic paracentesis in order to determine what is causing this deterioration of the patient. Sometimes we have to do therapeutic paracentesis And the main difference of therapeutic paracentesis from diagnostic paracentesis is that when we do therapeutic paracentesis, we usually remove a large volume of acidic fluid, sometimes 6 or even more liters of acidic fluid. And when do we do therapeutic paracentesis? When the patient is in severe pain. Obviously, when the patient's abdomen is severely distended, the patient will experience pain, and again, because of this, you have to remove a lot of fluid when the patient is in respiratory distress. Now, the presence of acidic fluid, especially when it is moderate to severe acidic fluid, can somehow paralyze the normal excursions of the diaphragm, which is the main muscle of respiration. And when this happens, the patient will have orthopnea, difficulty of breathing, patient might be hypoxic, and again, because of this, you must do therapeutic paracentesis. Also, when the patient has severe lordosis, this is the position that pregnant women usually assume during the third trimester of pregnancy. But when there is severe lordosis, this can lead to severe low back pain and sometimes interfere with normal ambulation. And again, you have to do therapeutic paracentesis. And when the patient has an abdominal hernia with signs of impending rupture, obviously, you have to remove the fluid in order to prevent the rupture of the umbilical hernia. Again, allow me to go back again to history. Again, this is Roman history. This is about Aurelius Cornelius Celsus, who wrote a medical journal around 25 BC up to 50 AD. And this is very, very close to Galen. But Aurelius Celsus is not a physician, but he was a philosopher, he was an encyclopedist, and he was a teacher. And yet, in his journal, he wrote about the treatments for patients with ascites. It was he who recommended that we use fig and honey poultice for patients with ascites, and he further recommended that if the belly is not dried up by this kind of remedies, and in spite of these remedies, the humor or the ascites, as it is referred to in the past, is in large amount, aid must be given in a quicker way. And of course, he recommended the quickest way, and that is to do it by direct issue to it through the belly itself, basically telling us that you have to do paracentesis in these individuals who are not responding to the usual treatment modalities for ascites. And in this picture, we can see here a Roman soldier, maybe of high stature, who has a tube inserted to the abdomen, and as you can see, this young lad catching the fluid that is draining from the tube from this patient. Aurelius Celsus did not only recommend the use of treatment modalities, and he did not also recommend only that we do paracentesis. He also described how it should be done. And you have to remember, ladies and gentlemen, that this was in 25 BC or around 50 AD. He said that we must make a perforation about 4 finger breadths below the navel and to the left. This was in 25 BC, and how accurate he can be. Basically, he is telling us that we must do paracentesis on the left lower quadrant area of this patient. Why so? Probably they did not know the scientific reason for doing it at that time, but they were obviously doing something that was correct, because now we also recommend that paracentesis should be done on the left lower quadrant area of patients with this problem. Why? Because you have to remember that patients with liver cirrhosis and ascites are sometimes taking some medications to treat orthosystemic encephalopathy. And of course, this is lactulose, and we will discuss this later on, but this is a laxative. But this laxative, lactulose, causes some distension of the large bowel. And what portion of the large intestine gets usually distended significantly? It is the cecum, and that is why if you do paracentesis on the right lower quadrant area, you might perforate the cecum and end up with the patient with something more serious like peritonitis. He did not only give the location, he also said that we can also perforate the navel itself through the umbilicus, which is also being done nowadays, especially if you're not successful with the left lower quadrant area. And he also mentioned that we must penetrate the membrane separating the flesh from the interior. See, he was referring to the fascia. We have to insert the needle through the skin, the subcutaneous tissue, the muscle, and the fascia in order to reach the peritoneal cavity and to be able to successfully drain the fluid from the peritoneal cavity. And of course, he says that we must use either a lead or bronze tube that should be inserted into the peritoneal cavity. This was excavated in a Roman city, and maybe these are the bronze tube that this guy used for paracentesis during the time. You can see here the complete translation of the book of Aurelius Cornelius to English. This is just a picture again of, this was not of course during the Roman times, this was in the late 16th century, 17th century. Again, you can see here a nobleman undergoing paracentesis, and you can see the tube inserted into the abdomen, and they were draining acidic fluid from this guy. So, but now, of course, this is how we do it properly. It is done now aseptically. It has to be done aseptically because you might introduce infection into the peritoneal cavity and end up with a patient with a more serious problem. Again, this is a needle. After thoroughly cleaning the abdomen, this is in the left lower quadrant area. A needle is inserted. This is the acidic fluid here. And now this is a closed system, and you can see the fluid now being drained into a bag. After this is filled up, this is of course discarded, and more fluid is drained until we get about 6 liters of the acidic fluid. There's a reason for getting at least only 6 liters of acidic fluid, because if we drain more than 6 liters of acidic fluid, we might have a patient who will develop a complication which we call as post-paracentesis circulatory dysfunction, PPCD. This is very common if we drain a lot of the acidic fluid, because the patient will develop hemodynamic instability and will develop circulatory dysfunction because of the large amount of fluid being removed, unless of course there is concomitant infusion also of albumin while removing large amounts of fluid. So if you want to remove more than 6 liters of acidic fluid, then the patient must be given also an infusion of albumin depending on the amount of the acidic fluid that must be removed. Is it frequently done in our institution, or is it frequently done by gastroenterologists? I know for a fact that most gastroenterologists would just drain at least 6 liters of acidic fluid and avoid removing more than that, because albumin infusion is quite expensive. So some caveats about paracentesis. It's a very rapid and cost-effective method of diagnosing the cause of ascites. The complications reported with this procedure is very rare, 1%, in spite of the fact that the majority of the patients with this problem maybe have already a coagulopathy because of liver cirrhosis, meaning that a lot of them will have a prolonged prothrombin time. The complications are very rare, especially if you have done it several times already and you're an expert in this. In the past, if the patient has liver cirrhosis because of the fear of the coagulopathy, prophylactic use of fresh frozen plasma or platelets were being given, but you see, this is just a waste of precious resources. The fresh frozen plasma or the platelet concentrate can be used by other patients who need them. Nowadays, we don't use it. It is no longer recommended. And as mentioned a while ago, the left lower quadrant is the best site for the paracentesis. You already know at this point in time why it is being done on the left lower quadrant area and not on the right lower quadrant area. Hopefully in the future, when you go to the wards, when you become clinicians, you can tell your students or even your residents that the left lower quadrant area is the best because of the reason I just gave you a while ago. And as I mentioned, there are very, very few contraindications for doing paracentesis, except when there is clinically evident fibrinolysis or disseminated intravascular coagulation. So what are the tests that we usually do on the acidic fluid that we aspirate from patients with this problem? There are routine tests, there are optional, unusual, and unhelpful tests. There's no point in remembering this, but the most important, of course, is you have to remember all of these routine examinations. The cell count, as I mentioned a while ago, the cell count is very important in determining the possible presence of a spontaneous bacterial peritonitis. The albumin in the acidic fluid, and I will show you this later on because we use this to calculate what we call as the SAAG, which is the serum, the acetic albumin gradient, and of course culture, if especially when there is a suspicion of an ongoing infection or a spontaneous bacterial peritonitis. So what is the acetic fluid well count in an uncomplicated ascites, meaning that there is no possible infection? You can see here that the mean WBC count of an uncomplicated ascites is less than 250 per cubic mil. And again, I would like to reiterate that I mentioned this a while ago, that if it is higher than this number, the patient must be given the benefit of the doubt and be treated as a case of spontaneous bacterial peritonitis. And I mentioned that we measure also the albumin in the acetic fluid because of this gradient, the serum ascites albumin gradient. If there's one thing that I hope you would remember from this lecture, and this is one of them, the serum ascites albumin gradient, it is very important for several reasons. One, it is of course a difference, it is not a ratio. It becomes important because if the difference is greater than 1.1 grams per deciliter, it is 97% sensitive, very high sensitivity in telling us that that acidic fluid is secondary to portal hypertension. And on the contrary, if the number is less than 1.1 gram per deciliter, again a very significant sensitivity, 97% sensitivity, telling us that the ascites is not secondary to portal hypertension. That is why, just by merely computing the serum ascites albumin gradient, you get a very, very sensible differential diagnosis as to the potential reasons or the potential cause of the ascites in the patient. So remember that if the gradient is high, think of portal hypertension, and these are the diseases that are usually associated with portal hypertension, and of course 85 to 90% it is most likely liver cirrhosis. And when we are talking about a low gradient, most likely it is not due to portal hypertension, and there are only probably two important reasons for a low gradient ascites. One is carcinomatosis, and the second is due to an infectious process like your tuberculous peritonitis. These are other reasons, but they are quite rare. Again, I would like to reiterate the fact that if it is high gradient, think of cirrhosis. If it is low gradient, beware because it might be carcinomatosis. Aside from that, if we know the serum ascites albumin gradient, we will also be able to determine whether the patient will respond to diuretics. So if the patient has an elevated SAAG, which means it is secondary to portal hypertension, then the patient's ascites might respond to the use of your diuretics, which we discussed a while ago, the use of furosemide and spironolactone given as a single dose in the morning. This is important because if the patient has an SAAG which is less than 1.1, again, indicating that this ascites is not due to portal hypertension, then the patient must never be given diuretics because the patient will not respond to diuretics. The ascites will not disappear with the diuretics. You are just adding to the problem of the patient because you are exposing him or her to the complications, to the electrolyte imbalance that will come, or the acid-base imbalance that comes with extended use of diuretics. Even if you give the patient a gallon of diuretics for 1 year or more, the ascites of this patient will not disappear because it is not due to portal hypertension. The gross appearance of the acidic fluid can also tell us a lot of things, like when the acidic fluid is transparent and yellow, This is a very good indication that you have an uncomplicated acidic fluid. The patient probably does not have an infection, but again, depending on the type of cells in the acidic fluid and the number of the cells, then the acidic fluid can appear cloudy or even mayonnaise-like, pinkish or reddish. It can appear cloudy and mayonnaise-like if the white blood cells are significantly elevated, and it can appear pinkish up to reddish, of course, if there's blood in the acidic fluid. One very important thing to remember is that when the acidic fluid is grossly bloody, not because of a traumatic tap, that acidic fluid most likely and has a very big chance that is due to a malignancy in the peritoneal cavity. There are other appearances of the acidic fluid that can tell us a lot of things, and like when it is opaque and milky, because if this is the appearance of the acidic fluid, then most likely the triglyceride level is greater than 1000 milligrams per deciliter, and if this is the case, then most likely this is secondary to lymphatic obstruction. Another important gross appearance of the acidic fluid, of course, is when it is dark brown, because when this is the case, then this means that the bilirubin level, if the acidic fluid is greater than 6 milligrams per deciliter, and if this is the case, this only means that there might be a leak or a rupture in the extrahepatic biliary system, because that is the only way that the bilirubin can find its way into the peritoneal cavity. And when this is the case, the patient must immediately be referred to a surgeon, because this is a potentially an emergency that can only be treated by an exploratory laparotomy of the abdomen. There are other tests that can be done on the acidic fluid, like your amylase, which can be elevated in patients with acute pancreatitis and gut perforation. In gut perforation, the pancreatic amylase that should remain in the small intestine and the bowel finds its way into the peritoneal cavity, and that's why the amylase will be elevated. Sometimes gram stain is being done by some clinicians on the acidic fluid, but you can see here that it becomes only positive only if there's a lot of load of bacteria per ml in the acidic fluid. But of course, this becomes very useful in patients with gut perforation, and because you can see a lot of the bacteria by doing just a gram stain of the acidic fluid. Cytology and sometimes can be done or is being done on acidic fluid, especially in those whom there's a high index of suspicion for malignancy. But you can see here that the sensitivity is from a very mediocre 58 to an average 75%, and that's why cytology is rarely done on acidic fluid. But of course, it becomes positive when the tumor cells line the entire peritoneal cavity. The cytologic test becomes very useful if it's positive, but if it is negative, it does not really tell you that there is no malignancy in the peritoneal cavity. This is laparoscopy. I mentioned to you a while ago that in the past we used to do laparoscopy in order to diagnose the reason for ascites, especially if most of the tests, ancillary procedures are negative. Sometimes the patient ends up with a laparoscopy in order to better identify the reasons for the ascites. This is, of course, the laparoscope. This is a modern laparoscope that is being inserted into the umbilicus and directly into the peritoneal cavity, and it is connected to a video screen, and this gives us the chance to examine the entire abdominal cavity, the abdominal organs, the visceral organs, without actually opening up the individual. This is a sample of a normal liver. It looks very normal. It is shiny, it is smooth. This is also a laparoscopic picture of a normal liver. You can see the edges are sharp. These are the fatty tissue on the surface of the liver. This is the area or the shadow of the gallbladder, which is just beneath the right lower quadrant of the right lobe of the liver. This is a laparoscopic picture of ascites, and you can see that this is classically a milky, opaque acidic fluid. And as I mentioned a while ago, when you see this, think of a possibility of a triglyceride level that is greater than 1000 milligrams per deciliter, and this can be found in patients with obstruction. This is, of course, Again, laparoscopic picture, and this is the left lobe of the liver that was lifted. Sometimes if the laparoscopist is not careful, they might miss the inferior surface of the left lobe of the liver, which can give a lot of information. As in this case, you can see this small nodule on the inferior surface of the left lobe of the liver that was biopsied and turned out to be this is the classical picture of a patient who has liver cirrhosis, and you can see here the right lobe of the liver with the nodularity of the entire liver. Classical of patients, again, a patient with liver cirrhosis, you can see the nodularity, but there are obviously bigger nodules here on the lateral aspect of the right lobe of the liver, on the inferior surface of the right lobe of the liver, another bigger nodule, which of course is very suspicious for the possibility of HCC. And these were biopsied. It turned out to be just simply regenerating nodules associated with cirrhosis. Again, classical finding of what we used to call as macronodular liver cirrhosis. In the past, we used to divide them to micronodular and macronodular depending on the size of the nodules, but now it is no longer being used because there seems to be no clinical distinction between what is micronodular and macronodular liver cirrhosis. An ultrasound, as I mentioned a while ago, we do ancillary procedures in patients with ascites. This is an ultrasound, and you can see here the left lobe of the liver, which is small, and you can see the nodular irregular surface. And again, as I mentioned, anything that is blocked by ultrasound is either fluid or air. And in this case, of course, this is fluid. This is acidic fluid in a patient who has liver cirrhosis. And aside from, of course, the information that the patient has cirrhosis and ascites, we can also get information as to the possible presence of portal hypertension by looking at several things. One, we look at the portal vein. Of course, it's not shown in this picture, but if the portal vein is dilated greater than 13 millimeters or 1.3 centimeters, and the splenic vein or is the superior mesenteric vein and the splenic vein is also dilated at greater than 1.1 centimeters. If there's a reduction in portal blood flow velocity, as seen by Doppler, if the spleen is large and has a diameter that's greater than 12 centimeters, and there is recanalization of the umbilical vein, as seen by ultrasound, then these are very distinct ultrasonographic findings or evidence of portal hypertension. Again, this is an ultrasound, but this was taken at the level of the umbilicus. You can see the fluid all over the place and the intestines which are floating at this level. This is another ultrasound, again showing us the ascites. Now a CT scan of the abdomen. Again, here you can see here the left lobe of the liver, which has a very nodular surface. It is small. This is the right lobe of the liver, and again you can see this ribbon-like structure surrounding the liver. I'm sorry. Again, this is the acidic fluid, but this is CT scan. You can see arrows pointing to a very large lymph nodes in this area, pointing to the possibility that the patient might have a malignancy with metastases to the adjacent lymph nodes. Of course, there's also a possibility that these lymph nodes are secondary to TB or hepatobiliary infection, hepatobiliary tuberculosis. So how do we treat patients with mild to moderate ascites? There are important treatment modalities that must be done in patients with mild to moderate ascites. First of all, of course, is the patient must discontinue alcohol, and we must treat the underlying cause. If the patient has chronic hepatitis B or C, this must be treated because it would significantly improve the patient condition. We avoid NSAIDs in patients with ascites because, as you well know by this time, that NSAIDs can affect renal function. It can lead to what we call as NSAID-induced nephropathy and worsen the problem of ascites in patients with liver cirrhosis. But the mainstay of the treatment of mild to moderate ascites is one, dietary restriction, limit the sodium intake to about 88 millimoles per day or about 2,000 milligrams per day. This is very difficult to compute, but dietitians will tell you that if you just remove the salt shaker from the table, and in our case Filipinos remove patis, toyo, or alamang bagoong from the table, then you might be able to successfully limit the intake of the patient to these levels of sodium per day. And the other mainstay of the treatment, of course, is the use of the diuretics, which we mentioned a while ago, furosemide and spironolactone at this concentration, 40:100 milligrams. Aside from this, there are other important things to remember, that when we are dealing with patients with mild to moderate ascites, we do not restrict fluid intake, because if we do so, this may only lead to hypernatremia. Fluid is restricted only if the sodium of the patient is less than 120 millimoles per day, and we limit the fluid intake to 1.5 liters per day. So remember that if you have a patient who has mild to moderate ascites secondary to portal hypertension, it is not justifiable to restrict fluid unless there is significant hyponatremia. Very important is that the patient's sodium intake must be limited, and that the patient must be started on the diuretic of furosemide and spironolactone. And how do we monitor whether the patient is responding or not? We check the whey regularly. And of course, if the patient is not responding, especially in patients with severe and refractory ascites, then we do paracentesis, and of course, maybe already refer the patient to a center where they can do liver transplantation. What are the benefits of treating ascites? We obviously improve the quality of life of patients with this problem. We concentrate the acidic fluid opsonins, which are proteins which are protections against infection, so they protect against spontaneous bacterial peritonitis. We reduce the risk of complications like cellulitis, hernia formation, or even rupture of the diaphragm. And of course, we reduce the amount of energy that the patient wastes for heating the acidic fluid, and by doing so, we diminish loss of weight and peripheral wasting of the patient.